So we'll be discussing about the approach to endocrine hypertension, because we are seeing a lot of cases of hypertension, and out of that almost 10 to 15% may are having some of the secondary causes, and without high index of suspicion that can be missed, and which can be potentially curable disease. So why it is important to identify secondary causes? First of all, because some of the secondary causes has particular target organ damage. Like if patient is having primary aldosteronism due to direct effect of aldosterone, it has very high incidence of coronaries as well as cerebrovascular accidents. BP fluctuations are there, especially in pheochromocytoma. It can lead to emergency, urgency, or even hypotension. Routine treatment may not be effective or even harmful. Like if you are giving beta blocker in a patient with pheochromocytoma, patient may land up into hypertensive emergency. There are specific treatments available, and some of them might be curable. Patient can be cured of hypertension, and that's why it is important to identify these secondary causes. And if we see the general clues, what are the general clues to see that this patient might be having some secondary cause of hypertension? When the onset of hypertension is at a young age, less than 40 years of age, you should think of having some secondary causes. There is new or sudden onset of hypertension before 20s or after 50s. That is also indicative of there might be some secondary cause. Severe or resistant hypertension. Patient is having history of accelerated hypertension or flash pulmonary edema. Sudden alteration in the blood pressure control, like patient is maintaining his blood pressure well and suddenly there are some fluctuation, we should think of other causes. There is family history of young onset hypertension or CVA, less than 40 years of age, and the patient is having hypertension with incidentally detected adrenal mass. In these cases, we have to think of some endocrine or the other causes of hypertension. Before embarking the difficult investigation of this resistant hypertension, we should confirm that hypertension is really resistant. We have to confirm that there is a treatment resistant. Patient should be at least on 3 antihypertensive, including diuretics. We should exclude the pseudo hypertension like poor BP technique, poor compliance of the medications, or the white coat effect. We have to identify and reverse the lifestyle factors like physical inactivity, alcohol, high salt intake. There are some medications which may cause increase in the blood pressure, and that should be taken care of. And after all these things are excluded, we should embark on the investigating the secondary causes of hypertension. There is long list of secondary hypertensions. The most common are the renal causes, which includes either renovascular or the renal parenchymal disorder. The second most common are the endocrine hypertension, and out of that adrenal is the most common, and we will be mostly talking about this adrenal causes of hypertension, which includes the pheochromocytoma, primary aldosteronism, Cushing syndrome, primary cortisol resistance, and syndrome of apparent mineralocorticoid excess. Apart from these adrenal causes, there are other causes including thyroid, parathyroid, acromegaly, even hypogonadism that can lead to hypertension. But these are the disorders which present with not only with hypertension but their own symptoms will be there. So let us go through the primary aldosteronism. It is the most common endocrine cause of secondary hypertension associated with higher incidence of target organ damage because of direct effect of aldosterone. It is having curable as well as targeted therapies available. And it is a syndrome of many etiologies. Just proving the primary aldosterone doesn't end your investigation, because it may be adenoma, it may be bilateral hyperplasia, it can be familial hyperaldosteronism. There are long list of causes for primary aldosteronism. But because of low index of suspicion and low rate of screening, the diagnosis less than only 1% are ever screened. Now let us go through one case. This is the case I have been passed through. This 42-year-old male patient who is obese, hypertensive for 7 years, recently detected to have type 2 diabetes, on multiple medications including diuretic, ARB, clonidine, but not controlled. Patient is having history of sleep apnea, and patient is having some documentation which shows that some hypokalemia is present. So because of this, patient is suspected to have some secondary cause or primary aldosteronism. So one question, which of the following is not associated with primary aldosteronism? Can we have voting please? So young onset hypertension, resistant hypertension, obesity, obstructive sleep apnea, or hypokalemia. So D, Okay, the maximum is with D, but the right answer is C. So obesity is not associated with in sleep apnea. Even if patient is having hypertension and sleep apnea, there is almost 34% incidence of that patient is having primary aldosteronism. So these are the clinical clues. So moderate to severe hypertension, resistant hypertension, hypertension with hypokalemia, adrenal incidentloma, sleep apnea, young onset hypertension, or family history of young onset CVA or hypertension. These are the clinical clues which suggest that patient might be having primary aldosteronism. So patient is routine blood investigation was done, almost normal, potassium was 3.7, renal Doppler, creatinine, all things were normal, and we have to screen for primary aldosteronism. The screening test for primary aldosteronism is aldosterone to renin ratio. The major question to us is that patient is on multiple medications because the screening protocol requires stoppage of some medication. So which medication needs to be stopped prior to aldosterone renin ratio? Voting, please. So C, yes, that is the most notorious and most important to stop before doing aldosterone renin ratio. But even if patient is on ACE inhibitor, ARBs, beta blocker, we can continue because most of the drugs are okay. Majority of drugs causes elevation in the plasma renin activity, and if patient even on medications, if plasma renin activity is suppressed, the test is valid. The aldosterone receptor blockers needs to be stopped at least for 6 weeks. Best regime for patient is for testing is alpha blocker plus verapamil. So the screening test was done. PSC was 28, PRA was 0.16, aldosterone renin ratio was 178. So what will be the interpretation? So I think the time is limiting. So the so maximum with B and C almost 50-50%. But the correct answer is B. It is primary aldosteronism and no confirmatory test is required because if we see the PSC-PRA ratio is a screening test, majority of cases will require confirmatory test. The confirmatory test includes oral sodium loading test or intravenous saline test, fluorocortisone suppression test. But if patient is having hypokalemia, suppressed renin activity and PSC more than 20, in that case you don't require confirmatory test. You can directly go ahead for imaging. And that's what we do in this case, and it has shown that there is bilateral adrenal enlargement. Though the one side size is little bit larger, but the other side was small. Ideally, this patient should be undergone for adrenal venous sampling to lateralize that which side of adrenal is secreting more aldosterone. But patient was not willing. Patient started on spironolactone, that is medical therapy. It is titrated to normalize blood pressure, avoiding hyperkalemia, and because of that, the other antihypertensive medications, dosage of that medication was going down. Now coming to pheochromocytoma, it is uncommon, 0.2% of all hypertensive patients. It can be either adrenal, extra-adrenal. There is 10% risk of malignancy, and it can be associated with some malignant familial syndromes. And when to suspect this pheochromocytoma, it is again, there is hyperadrenergic spells. Patient is having paroxysm of palpitation, perspiration, and headache. There is resistant hypertension. There is family history of these syndromes or pheochromocytoma is present. Any patient who is detected to have adrenal incidentloma should be investigated for pheochromocytoma. And also there is a idiopathic dilated cardiomyopathy. In that case, we need to confirm that the patient is not having pheochromocytoma if patient is hypertensive. So which screening test you prefer for pheochromocytoma? It is, can we have voting please? So the maximum is between B and D. So 24-hour urinary VMA, it is very, very old test. Though it has very less sensitivity, But right now the standard of care is plasma metanephrine and free metanephrine, because of it is having very high degree of sensitivity, and there is very less chance that you miss any of the cases who is having pheochromocytoma. And especially when there is high index of suspicious is there, plasma metanephrine and normetanephrine should be ordered. After that, there is, once it is confirmed biochemically, you should embark on the localization of this pheochromocytoma, starting with CT, MRI, followed by functional scan you can do, that is MIBG scan and FDG PET. There are few particular indications for doing this MIBG scan when there is very large pheochromocytoma, there is bilateral pheo, very young pheo. In those cases, we have to do MIBG scan to rule out that there is no other lesion is present anywhere. Preoperative preparation is important for managing pheochromocytoma. At least 10 to 14 days prior to surgery, it has to be started. Alpha blockage should be started. Phenoxybenzamine is the drug of choice, sometimes not easily available. We can go for selective alpha-1 blocker like prazosin. Along with the high sodium diet, beta-adrenergic blockage can be added after 3 days if blood heart rate is not controlled, or we can add calcium channel blockers. This is the last slide. There is a huge list of other endocrine disorders which can have hypertension, but they are primarily present with their own symptoms rather than hypertension alone. However, one of the causes which I like to highlight is the primary hyperparathyroidism. Many of the cases are asymptomatic, and serum calcium is necessary whenever we are doing the evaluation for this secondary hypertension. So thank you.